Hello and welcome. Today we're diving into a common yet often misunderstood condition affecting the urinary system, vesicoureteral reflux, or VUR. We'll explore what it is, why it happens, how it's diagnosed, and what can be done about it. So, what causes vesicoureteral reflux? In essence, it stems from a faulty valve mechanism where the ureters connect to the bladder. Normally, this valve prevents urine from flowing backward. In primary VUR, this valve is underdeveloped from birth. Imagine a flap that's too short or positioned incorrectly. Secondary VUR, on the other hand, occurs because of a blockage or malfunction further down the urinary tract. Conditions like posterior urethral valves, a congenital obstruction in boys, or even recurrent bladder infections causing bladder dysfunction can lead to increased pressure, forcing urine back up the ureters. Now, let's understand the pathophysiology. Normally, when you urinate, urine travels from the kidneys down the ureters and into the bladder. Then, the bladder contracts and urine exits through the urethra. In VUR, this one-way flow is disrupted. Imagine a dam with a leak. Urine flows backwards from the bladder up the ureters and potentially all the way back to the kidneys. This retrograde flow introduces bacteria from the bladder into the upper urinary tract, which are normally sterile. Repeated backflow can damage the kidneys, leading to scarring, high blood pressure, and even kidney failure in severe cases. Vesicoureteral reflux is more common than you might think, particularly in children. It's estimated to affect around 1% of all children. It's often detected after a child experiences a urinary tract infection, or UTI. There is a genetic component. VUR tends to run in families, so siblings of children with VUR are more likely to have it as well. However, it can occur sporadically too. The signs and symptoms of VUR can vary. Many children with mild VUR have no noticeable symptoms at all. More severe VUR often presents with recurrent urinary tract infections. These UTIs might be accompanied by fever, abdominal or flagrant urination, painful urination, and bedwetting. In infants, symptoms can be more vague and include poor feeding, irritability, and failure to thrive. It's important to remember that VUR can exist without obvious symptoms, especially in milder cases. Diagnosing VUR typically involves a combination of tests. A urinalysis helps identify signs of infection. An ultrasound can detect abnormalities in the kidneys and bladder. The gold standard for diagnosis is avoiding cystoarthrogram, or VCUD. This involves inserting a catheter into the bladder and filling it with a contrast dye. X-rays are then taken while the child urinates, allowing doctors to visualize any backflow of urine into the ureters. Another test, a radionuclide cystogram, is sometimes used. It uses a radioactive tracer instead of contrast dye and often involves less radiation exposure. VUR is classified into grades, typically from I to V, based on the extent of the reflux. Grade I involves reflux only into the ureter, without reaching the kidney. Grade II reflux reaches the kidney but doesn't cause dilation or swelling of the renal collecting system. Grade IIIR involves mild to moderate dilation of the ureter and renal collecting system. Grade IV includes moderate dilation and tortuosity, or twisting of the ureter and renal collecting system. Finally, Grade V is the most severe, with significant dilation and tortuosity of the ureter and collecting system, along with blunting of the renal calyces, which are cup-like structures in the kidney. Treatment for VUR depends on the grade of reflux, the child's age, and the presence of symptoms. Mild reflux like grades I and II often resolve spontaneously over time. In these cases, the primary approach is observation with prophylactic antibiotics. These low-dose antibiotics help prevent UTIs and kidney damage. More severe reflux, like grades IV and V, may require surgical intervention. Surgical options include open surgery, in which the ureter is reimplanted into the bladder to create a better valve mechanism. Another option is endoscopic injection, where a bulking substance is injected around the ureteral opening to improve its function. The chosen treatment depends on individual factors and is made in conjunction with a pediatric urologist. Preventing VUR itself is not possible, as primary VUR is a congenital condition. However, steps can be taken to prevent UTIs in children with VUR, which in turn helps prevent kidney damage. These steps include encouraging frequent urination, teaching proper hygiene to prevent bacteria from entering the urinary tract, and ensuring adequate fluid intake. Circumcision in males can also reduce the risk of UTIs. The prognosis for VUR is generally good, especially when it's detected early and managed appropriately. Many children with mild reflux outgrow the condition without any long-term complications. With appropriate management, including antibiotics, and if necessary, surgery, the risk of kidney damage is significantly reduced. Recent research is focusing on identifying genetic markers for VUR, which could lead to earlier diagnosis and more targeted treatment. Researchers are also exploring less invasive surgical techniques to minimize complications and recovery time.